Welcome to AETCM, the Emergency Medicine Channel. As a part of EMRAPID 2024, today I am presenting topic is hyperbaric oxygen therapy. Hyperbaric oxygen therapy is a medical intervention in which a patient breathes continuous or intermittent 100% oxygen while inside a hyperbaric chamber that is pressurized to an ambient pressure greater than sea level. Hyperbaric oxygen therapy, that is HBO, result in systemic delivery of oxygen that produces supraphysiologic oxygen tension in perfused tissues. The effect of hyperbaric oxygen therapy are due to combined effects of both increased ambient pressure and increased oxygen tension. Contain monoplace chambers and multiplace chambers. In monoplace chambers, accommodate a single occupant. An attendant monitors the patient from outside and communicates via intercom. Specially designed cardiopulmonary monitoring devices, IV infusion pumps, and ventilator enable critically ill patients to be treated in monophasic chambers. In multiplace chambers, can simultaneously treat multiple patients and will accommodate medical personnel inside the chamber to perform hands-on patient assessment and care. Monoplace chambers generally use 100% oxygen for pressurization, and whereas multiple units are pressurized with air and patient breathe oxygen using a face mask, a hood, and endotracheal tube while inside. Ambient pressure is an important concept in HBO therapy. Sea level, the pressure exerted by the air column above is quantified as 1 atmosphere absolute of pressure, that is ATA, which is 760 millimeter mercury or 101 kilopascal. Once a patient is placed inside a chamber, the ambient pressure is increased by the gradual inflow of compressed gas, either oxygen or air. Most HBO therapy uses pressures between 2 and 3 ATA. A typical HBO treatment lasts 90 to 120 minutes. HBO therapies are performed using a preset protocols that define pressurization level, treatment duration, use of air breaks, and number of HBO sessions in a course of therapy. The oxygen content of the blood is the sum of oxygen carried by the hemoglobin and the oxygen dissolved in the plasma. Hemoglobin becomes fully saturated around a partial pressure of 100 millimeter mercury. And fully saturated hemoglobin carries approximately 20 ml of oxygen per 100 ml of blood, which is expressed as a 20 OD percentage. At 1 ATA breathing room air, dissolved oxygen plasma typically only 0.3 OD percentage. At a pressure of 3 ATA inside a HBO chamber, pressurized with 100% oxygen, the arterial oxygen tension, that is partial pressure of oxygen, will approach to 2200 millimeter mercury, which will brings the dissolved oxygen content from 0.3 volume percentage to 5.4 volume percentage. This amount of dissolved oxygen can sustain basal metabolic function in the complete absence of hemoglobin. Physiological effects of HBO. HBO therapy should be viewed as a drug and hyperbaric chamber as a delivery device. HBO affects the tissues in two ways. There are effects related to mechanical forces of increased pressure and effects due to hyperoxygenation. Of the two, elevated tissue oxygen tension is thought to be primary effect. Hyperoxygenation reverses tissue ischemia. It also induces the formation of reactive oxygen species, including superoxide, hydrogen peroxide, hypochlorous acid, hydroxyl, and reactive nitrogen species. This stimulates the body's natural antioxidant defense mechanism and strongly mobilizes the antioxidant enzyme systems and thus improving the defense from oxidative damage. Highly elevated oxygen levels generated during HBO therapy have therapeutic beneficial effects seen after tissue oxygen levels return to normal. These reactive oxygen species are natural byproducts of metabolism that can oxidize proteins and membrane lipids, which can damage the DNA and mediate tissue and organ damage seen in oxygen toxicity. The body has a scavenger antioxidant system to reverse the oxidative damage caused by reactive oxygen species generated during HBO therapy, and that continue to protect the body against the oxidative stress upon completion of HBO therapy. Beneficial effects of hyperbaric oxygen therapy. It provides hyperoxygenation, which leads to reverse the tissue ischemia. Limits the toxin production, which will inhibits the microbial enterotoxin and exotoxin production in bacteriostatic and bactericidal action to obligate anaerobic microorganism. Reduces tissue edema, induces vasoconstriction mediated reduction of inflow without reducing the outflow in post-traumatic tissue beds, stimulates angiogenesis, promotes production of oxygen-dependent collagen matrix, increases wound growth factor synthesis, and mobilizes stem or progenitor cell from bone marrow. It promotes osteogenesis in hypoxic bone by providing osteoblast stimulation and bone tissue regeneration, promotes wound healing by impairing beta-2 integral function and amplifying oxygen gradients surrounding the ischemic wounds, which diminishes inflammatory responses by lowering the monocyte chemokine synthesis and ischemic preconditioning changes in heme oxygenase 1, heat shock proteins, and hypoxia-inducible factor. It augments fibroblast replication, increasing collagen formation. In blunt ischemia repulsion therapy to endothelial tissue, increased red blood cell flexibility leads to facilitating increases elastic deformation. Enhances leukocyte bactericidal activity, leads to improves the neutrophil oxygen-dependent peroxidase bactericidal activity. Enhances the antibiotic transport, increases the antibiotic penetration into target bacteria. Preserves intracellular adenosine triphosphate, supports the intracellular function. Eliminate lipid peroxidation, obviating tissue destruction. An indication of HBO therapy. Acute ischemic events like arterial gas embolism, decompression sickness, central retinal artery occlusion, sensorineural hearing loss, and problematic wounds, exceptional blood loss anemia. In traumatic injuries like crush injury and compartment syndrome, other acute ischemias, acute thermal burns, compromised graft and flaps. Coming to gas toxicity, carbon monoxide poisoning, cyanide poisoning, coming to infections like Clostridial myonecrosis, necrotizing soft tissue infections, intracranial abscess, and refractory osteomyelitis. Coming to radiation injuries like osteoradionecrosis, soft tissue necrosis. Coming to air or gas embolism. Air or gas embolism can occur as a consequence of deep sea dive related accident or as a result of medical procedures including emergent or urgent procedures performed within the ED. Air or gas embolism can occur either on the venous or arterial side of the circulatory system. Venous gas embolism can occur after surgical procedures. The amount of gas is typically small and the air bubbles trapped in the pulmonary capillaries are reabsorbed without symptoms. When large quantities of gas in the pulmonary vasculature can stimulate cough, dyspnea, and pulmonary edema, and in severe cases causes vapor lock. A paradoxical arterial gas embolism may develop when the venous gas embolism travels to the arterial system by right to left shunt by way of intrapulmonary shunt or through an arterial septal defect or patent foramen. The consequence of an arterial gas embolism depends on location and the magnitude of the arterial occlusion. In skeletal muscle, connective tissue, and skin can often tolerate the small emboli, but air entering the coronary, cerebral, and spinal circulation can precipitate acute coronary syndrome, stroke, or paralysis, respectively. The introduction of intravascular sheath, such as at the start of an interventional radiological procedure, accounts for greatest proportion of iatrogenic gas embolism. When suspected, administer supplemental oxygen to support arterial oxygenation and hasten the bubble resorption. Place the patient in a supine position, and there is no proven benefit to a head-down position to lower the risk of additional cerebral air embolization, or a left lateral decubitus position to trap the gas within the apex of right ventricle and minimize the migration. Catheter aspiration of trapped air may be attempted in those rare instances when it is visualized and a pre-existing catheter is in place, and de novo placement of vascular catheter to attempt air aspiration is controversial. HBO is a definitive treatment for arterial gas embolism, and it is recommended when there is neurological or cardiovascular impairment. Start treatment as soon as possible, but there is evidence of improved outcomes out to 60 hours or longer. The most common protocol used in the US Navy treatment is Table 6, which begins at 2.8 ATA with subsequent decompression to 1.8 ATA. For patients whose symptoms are not improved or worsened, the US Navy treatment Table 6A may be considered. For patients with residual symptoms after the initial HBO treatment, additional treatments are recommended until there is no further neurological improvement. Coming to decompression sickness, decompression sickness is due to the formation of nitrogen bubbles in the body tissue and circulation during decompression. These bubbles cause direct mechanical disruption of tissue, occlusion of blood flow, platelet deposition, and activation of the coagulation cascade. Endothelial dysfunction, capillary leakage, endothelial cell damage, and complement activation and leukocyte endothelial interaction. HBO treatment is a definitive treatment for decompression sickness and recommended in all cases of diving decompression sickness. If HBO therapy is not available, the patient with mild symptoms who are stable for longer than 24 hours may be treated with supplemental oxygen alone. If a patient must be transported by air to a hyperbaric facility, use pressurized aircraft to maintain sea level pressure or transport at the lowest possible altitude in a non-pressurized craft such as helicopter. A variety of HBO regimens are used to treat decompression sickness, but most centers use US Navy treatment Table 6 and most patients with decompression sickness who receives rapid HBO therapy will respond to a single treatment. The US Navy treatment Table 9 may be used in patients with residual symptoms. Coming to in central retinal artery occlusion. In central retinal artery occlusion is rare, it's usually presenting as a painless vision loss in one eye without treatment, and vision loss can be permanent. Poor outcomes occur because the occlusion is often the result of a cholesterol embolus that is not treatable with thrombolysis. HBO therapy produces a clinically significant visual improvement, especially when instituted within 24 hours of onset. There are no other central retinal artery occlusion therapy with similar outcomes. Adjunctive therapies are recommended until HBO can be initiated. HBO central retinal artery occlusion protocol is 2 ATA for 30 minutes. If vision improves, the patient is treated for a total of 90 minutes. Treatments are done twice daily and continued until there is no visual improvement for 3 consecutive days. If vision does not improve at 2 ATA for 30 minutes, the pressure is raised to 2.4 to 2.8 ATA for a total of 90 minutes with air breaks. If there is no improvement after 8 treatments, visual recovery is unlikely. Coming to in sudden sensorineural hearing loss. Sudden sensorineural hearing loss is hearing loss of at least 30 decibel occurring over a 3 days involving at least 3 contiguous auditory frequencies. The usual presentation is of a patient waking from sleep with a sudden unilateral hearing loss, oral fullness, and at times tinnitus and vertigo. The cause is unclear, and many mechanisms have been described, including ischemia, trauma, toxins, vascular occlusion, viral infection, immune-associated disease, abnormal tissue growth, and labyrinthine or cochlear membrane damage. HB therapy is effective primarily by achieving extremely high arterial perilymphatic oxygen concentration. In combination with steroids, HB therapy produces hearing gains over all frequencies. HB therapy is indicated for profound sudden sensorineural hearing loss, which is more than 40 decibel within 14 days of symptom onset. It is essential that both corticosteroids like prednisolone 60 milligrams orally daily for 7 to 14 days and then tapered over 1 to 2 weeks with HVO therapy like 100% oxygen at 2 to 2.5 ATA for 90 minutes daily for 10 to 20 sections can be used together. Coming to exceptional blood loss anemia, in case of acute severe anemia where transfusion cannot be used to improve the oxygen content to a sustainable level, HBO aids in sustaining the life. The benefits of HBO include rectifying the oxygen depth, providing a bridge that corrects the end organ damage, and allowing time for the patient endogenous erythropoietin levels and baseline hemoglobin to rise. The HBO treatment protocol is 100% oxygen at 2.5 to 3 ATA for 3 to 4 hours, up to 4 times daily to raise the PO2 in plasma to meet the metabolic needs until red blood cell concentration improves. Coming to crush injuries, in crush injuries damage multiple tissues, creating a cycle of edema and ischemia. Approximately half of patients with severe injuries develop complications such as osteomyelitis, fractured non-onions, amputation, and failed flap despite optimal surgical and medical care. HV treatment is effective in reducing the complication and promoting the healing in such patients. HV protocol for crush injuries is 2.4 ATA for 100 minutes, 3 times daily of 2 days, then twice daily for 2 days, followed by once daily session for 2 days. In compartment syndrome, the standard therapy for compartment syndrome is fasciotomy to decompress the compartment and reverse the ischemia of enclosed muscles and nerves. Fasciotomy itself has associated complications, and in the situation of impending compartment syndrome, HVO can improve the oxygenation to hyperperfused tissues and promote arterial hyperoxia and decrease the vasoconstriction and edema and prevent the progression. In acute thermal burn injury, animal models have shown significant benefits of HBA for thermal burns, including reducing the partial and full thickness skin loss, hastening the epithelialization, and lowering the mortality. Many clinical trials have reported significant improvement in healing and decreased length of stay and decreased mortality, reduced the cost of care, improved the morbidity, decreased the fluid requirement, and decreased surgical procedures. HB protocol for treatment of thermal burn is 2.4 ATA for 100 minutes with 2 air breaks, and treatment begin 3 times daily, then decrease to twice daily, then once daily as healing occurs. In carbon monoxide poisoning, carbon monoxide toxicity develops from impairment of hemoglobin function and direct carbon monoxide mediated cellular damage that poison the electron transport chain and inhibits the adenosine triphosphate formation. It's ATP. After removal from continued carbon monoxide exposure, the carbon monoxide slowly dissociates from the hemoglobin and electron transport chain and is metabolized or exhaled. Treatment with HBO enhances elimination of carbon monoxide from the body. The two HBO protocols have been studied for carbon monoxide poisoning are Salt Lake City Protocol and Philadelphia Protocol. In Salt Lake City Protocol uses 3 ATA for 60 minutes with 2 air breaks, followed by reduction to 2 ATA for 65 minutes with 1 air break. The two additional treatments are given in 6 to 12 hours interval. Coming to Philadelphia Protocol, which is a single treatment at 2.8 ATA for 30 minutes, followed by a 2 ATA for 90 minutes. In cyanide poisoning, concomitant cyanide and carbon monoxide poisoning may be seen in patients rescued from closed space fires in which synthetic materials are burned. HVO may directly reduce the cyanide toxicity and or augment other antidote treatment. However, cyanide is among the most lethal poison and toxicity is rapid, so standard antidotal therapy for isolated cyanide poisoning is of primary importance. And HBO can be considered in case of dual carbon monoxide and cyanide poisoning. And in cyanide poisoning, when vital signs and mental status do not improve with antidote treatment, we can use HBO therapy. In necrotizing soft tissue infections, necrotizing soft tissue infections, including necrotizing fasciitis and Fournier's gangrene, are rapidly spreading, deep, typically mixed infection that result in profound morbidity and mortality. HBO is a valuable adjunct to surgical debridement and antibiotic therapy in necrotizing soft tissue infections, reducing the mortality, improving the recovery states, and decreasing both amputation rate and the number of required surgical interventions. HBO is beneficial due to its ability to suppress the growth of anaerobic microorganisms, improves the bactericidal action of leukocytes that functions poorly in hypoxic condition, and enhances antibiotic penetration into the target bacteria. HBO protocol for necrotizing soft tissue infection is twice daily treatment with 2 to 2.5 ATA for 90 minutes with 2 air breaks until the extension of necrosis halted. and then daily until the inflammation is well controlled up to 30 sections. In Clostridial myonecrosis, like gas gangrene, in gas gangrene is an acute and rapidly progressing clostridial infection of muscle tissue characterized by profound toxemia, edema, tissue death, and variable gas production. The induction of gas gangrene occurs only in the presence of Clostridial spores in a region of lowered oxidation reduction potential caused by a local circulatory failure or extensive soft tissue damage or muscle necrosis. Under this condition of low oxygen tension, the Clostridial spores can develop into vegetative form. The pathogenesis of gas gangrene involves production of Clostridial exotoxins, of which more than 20 have been identified. Alpha toxin is the most prevalent exotoxin and causes platelet and leukocyte destruction, widespread capillary damage, hemolysis, tissue necrosis, and often death. Alpha toxin can be detoxified within hours after its elaboration, with natural host defense conferring active immunity with production of a specific antitoxin. However, death often occurs because the infection is so rapidly progressive that the patient dies before the immunity can develop. The primary benefit of HBO therapy for gas gangrene is that inducing an oxygen tension of 250 to 300 mm mercury achieved at 3 ATA, which halt the alpha toxin production, inhibit the clostridial growth, and allows normal host factors to swiftly detoxify the patient so that a moribund patient can rapidly be made non-toxic. Treatment begins with an index of suspicion and a positive gram-stained smear of the wound fluid revealing gram-positive rods and a positivity of leukocytes. Although treatment with gas gangrene involves three-pronged approach: antibiotic, surgical management, and HBO. The initial surgery can be restricted to opening of the wound or initial fasciotomy, followed by immediate HBO therapy. Lengthy and extensive procedures in gravely ill patients may be deferred, with necrosis tissue debridement performed between HBO session when a clear demarcation between the dead and the viable tissue is appreciated. The HBO protocol for treatment of gas gangrene is 3 ATA for 90 minutes, 3 times a day in the first 24 hours, then twice daily for the next 2 to 5 days. In several series, no mortality has been shown after the third session. Coming to the complications of HBO therapy, one is barotrauma. Middle ear barotrauma is the most common adverse effect of HBO treatment. As the ambient pressure within the hyperbaric chamber increases, a patient must be able to equalize the pressure within the middle ear by autoinsufflation or else ear pain, tympanic hemorrhage, serous effusion or rupture will develop. Standard protocol include instructions on autoinsufflation techniques and medical therapy when needed. When these interventions fail, tympanostomy tubes must be placed in order for HBO therapy to continue. Pulmonary barotrauma during HBO treatment is extremely rare but should be suspected when significant chest or hemodynamic symptoms occur during or shortly after decompression. If symptoms develop and the patient is in multiplex chamber, stop the decompression and evaluate for pneumothorax. If the patient is in monophasic chamber, slowly decompress and provide supplemental oxygen upon returning to ambient pressure. Next is oxygen toxicity. The biochemical oxygen toxicity can injure the brain, lungs, and eyes. Acute oxygen toxicity manifests as grand mal seizures reported to occur approximately 1 to 4 times per 10,000 patient treatment. The risk of seizure is higher in hypercapnic patients and possibly those who are acidotic or septic. Seizures are managed by reducing the inspired oxygen tension while leaving the patient at the same pressure. Chronic oxygen toxicity can impair the lung mechanism, elasticity, vital capacity, and gas exchange. These exchanges are typically observed only when treatment duration and pressures exceeded typical HBO protocol. Progressive myopia has been reported in patients who undergo prolonged daily therapy and typically reverses within 6 weeks after stopping HBO therapy. There is a risk for nuclear cataract development typically when treatment exceeds a total of 150 to 200 hours but they may arise with less provocative exposure. Other miscellaneous complications are confinement anxiety may occur and typically managed with sedating agents. Any environment with elevated concentration of oxygen presents a risk for fire. Surplus evidence of ignition source is standard in HBO therapy programs. Thank you.